Okay, hello everyone. This is the case number 5. We are already in a series of cases. We discuss critical diagnoses and management and treatment, etc. This is the 5th one. Our case today is about patient with generalized weakness. Let's get started. So the case presentation said a 28 years old woman present with 3 months of history of fluctuating asymmetric ptosis, diplopia, and fatigable proximal limb weakness, which is worsening toward the end of the day. There is associated nasal speech and dysphagia for liquids. Past medical history is notable for autoimmune hyperthyroidism. There is a family history reveals a mother with rheumatoid arthritis and sister with SLE. Vitals shows a febrile patient with a normal blood pressure, heart rate of 82 normal, regular, and also a normal respiratory rate, saturation of 99. So as we used to do in our previous cases, we start with the presentation, then we start to think about what type of physical examination should we proceed with. So you can pause here and think about what type of physical examination you should do. I will carry on. So we've done general physical examination, which is showed a well-nourished young woman, sitting comfortable, speaks in full sentences. Head and neck was asymmetric, fatigable. There is a bilateral ptosis with a normal pupils, bilateral facial weakness, and there is also a nasal hypophonic speech. Okay, otherwise unremarkable. Cardiovascular a normal. There is no anything concerning here. Respiratory is also normal. Chest expansion is symmetric. Normal breath sounds. There is no wheeze or crackles. Extremities shows no muscle atrophy or fasciculations, and a normal deep tender reflexes response. Neurological shows a normal mental state, alert patient, and also oriented with normal cognition. So here, according to our physical examination and our first presentation, you can go back, see the physical examination again and the case presentation, and we should start forming our differentials. Since it's not emergency, there is no any acute management needed in this case, so we form our differentials. You can pause here, think by yourself to what kind of differentials you should put in your list. Start with the most likely, and the more you go further down, it means that it's less likely to be the diagnosis. Okay, so our differentials starting with myasthenia gravis, which is the most likely diagnosis in this case. Lambert-Eaton myasthenic syndrome, or other name is Lambert-Eaton gravis. Okay, botulism toxic, and hyperthyroidism, which is a thyroid ophthalmopathy. It could be only intracranial mass lesion, progressive external ophthalmoplegia, which is a mass compressing in the region of the eye. That's also another probability. And whenever we go down, this is the less likely, which is starting from intracranial mass to drug-induced myasthenic syndrome to the last one, which is multiple sclerosis. Okay, so once we've formed our differentials, now comes that we need to do our workup according to this differential. So we start with the highest one, which is myasthenia gravis in this case, and Lambert-Eaton syndrome, and to the last one, which is multiple sclerosis and tumors. And we start order our workup to see which diagnosis it fits in this case. You can pause here, think about what kind of test we need to order, and let's proceed. So we order CBC, CMP. Of course, this is always keep this because you want to see any processes of anemia or like a chronic inflammation, since we have a autoimmune disease in our differentials. CMP, always you want to see calcium, potassium, sodium. We want to see the electrolytes in the body, how they are doing. Okay, ESR CRB, since it's autoimmune disease and there's inflammations, you need to order those to keep this in your mind for covering any kind of chronic inflammation. ABG. Why? Because here we have in our highest differentials, we have myasthenia gravis and Lambert-Eaton syndrome, and we want to check if the lung or the pulmonary system is already functioning normally. There's no issue, okay? So this is an important test. PFT, also important pulmonary function test. Since we have myasthenia gravis in our highest differential, we want to know if there is any problem in the lungs or not, okay? Acetylcholine receptor antibody, this is help us to confirm the diagnosis of myasthenia gravis. EMG also will help us to know if it's myasthenia gravis or Lambert-Eaton syndrome. TSH to help us rule in or rule out thyroid issues. Chest CT. Chest CT in this case, we are ordering this for a specific condition which is associated with myasthenia gravis. We will talk about this. And brain CT because we want to rule in or rule out a multiple sclerosis. Sometimes MRI is better, not sometimes, most of the time MRI is better actually, but CT it's more faster and will rule out two things since we have a intracranial mass in our differential, plus we have also multiple sclerosis. So let's see our labs. CBC was normal, CMP was normal, there is no any inflammation, there is no any anemia here, everything is clear. ESR CRP is also normal. EBG show a normal pattern, so this is telling us that the lungs are functioning normally, there's no issue here. PFT also show a baseline spirometry without any obstructive or restrictive pattern. Acetylcholine receptor antigens shows a positive here, which means that it's confirming the diagnosis of myasthenia gravis, and EMG also supporting this is showing a markedly increased jitter with occasionally impulse blocking in weak muscle. Okay, so those two tests actually they confirm the diagnosis of myasthenia gravis. Okay, so here just we need those two tests and boom, you have myasthenia gravis here confirmed. TSH is normal. This is ruling out a thyroid issue. Chest CT was showing what. This is why we ordered the chest CT to wanna see if the patient have thymoma or not. Okay, which is thymoma here, since we have a thymic enlargement. Because every 10 patients who have myasthenia gravis, 7 of them they will have a thymoma. Okay, brain normal, CT shows no anything. Let's carry on. So the diagnosis was myasthenia gravis in this case. Now we will start our management. We give symptomatic therapy, also the immunosuppression, and we close monitor the patient for any neuromuscular crisis, etc. I will talk about this more rapid in our talk about myasthenia gravis. So what is myasthenia gravis? Myasthenia gravis basically it's an autoimmune disease affecting the neuromuscular junction. And let me just skip this one. Yeah, this is the picture I need. So here we can see that there is in each end of neurons there is kind of junction here. Okay, and at this junction you can see this is the presynaptic part and that's the postsynaptic part. Okay, so here's the pre, here's the post and pre. Okay, and between the junction middle of it you can see that acetylcholine is secreted and bind to its own receptor, for example here. Okay, so normally it's bind to its own receptor and everything looks good and everything works normal. But if we have myasthenia gravis, what has happened, the body start to forming antibodies, and they start to bind to the own receptor of acetylcholine and block them. So acetylcholine will start move here and cannot find a receptor binds to it, so the problem happened. Okay, that's in very short brief explanation. That's why we have the disorder. Okay, there is another disorder which looks like myasthenia gravis. It's called Lambert-Eaton syndrome, which was the second differential in our list. In this disease, there is no antibody to the acetylcholine receptor, but there is antibodies to what? To the calcium gated channel, okay, voltage gated channel. In this case, that's Lambert-Eaton syndrome here. Okay, let's take care of those both, because both of them have the same have the same symptoms. The only difference is about the character of the symptom. Myasthenia gravis, it gets worse whenever you use the muscles, and for the Lambert-Eaton syndrome, it gets more good if you use the muscles. We're going to talk about this more details. Going back, so myasthenia gravis is an autoimmune disease which is affecting the postsynaptic neuromuscular junction. We already discussed this. And as we know, wherever you have a history of autoimmune disease, always think about the property of having another autoimmune disease. Okay, in this case, had a hyperthyroidism, I guess, as I remember, and also her sister had systemic lupus, her mother had rheumatoid arthritis. So autoimmune disease, it runs in the family. So always, when you have a vignette, especially in the exams, okay, when you have a vignette which is they have a autoimmune disease, they have a high probability to have another one. Okay, and usually is seeing in the third decade of women and older in men, seeing more women. Okay, let's carry on. So what is the clinical symptoms as the case we saw it here? If you get confused and you don't know what myasthenia gravis looks like, think about weakness in the whole body, okay, everywhere. Weakness in the proximal muscles, weakness in the distal muscles of the hand, of the foot, eyes, and especially the face, okay. The face is the most of the time you will see it affected in case of myasthenia gravis. So the patient will have ocular symptoms like ptosis, which is a closure of the eyelid over the eye itself, diplopia, double vision, blurred vision. Sometimes you see bulbar symptoms, which is a difficulty with the swallowing, difficulty with a talking, a showing issues, and also facial weakness. Limp, you can see neck weakness, limp weakness, and waddling gait. Okay, and the scenario which is we don't like to see, and the last one, which is myasthenia crisis. This is an important one. We're gonna talk about how to manage this, because this is what we are afraid from in case of myasthenia gravis. The diagnosis, there is a 3 parts actually in diagnosing the myasthenia gravis. We have the clinic and the serology, and also based on imaging. So clinically, most of the time you will guess that you will give a presumptive diagnosis that clinically the patient looks like he had myasthenia gravis, especially if the patient have a respiratory issue, because there is no time to diagnose or wait the serology until they comes back and you have patient who have respiratory issue. If you have a patient with myasthenia crisis, which we already mentioned here, and they have respiratory symptoms, okay, for example, shortness of breath, they cannot breathe, or like a difficulty walking because of like breathlessness. In this case, you should do intubation directly. Okay, there is no talk here. Intubate the patient, because we are afraid that we're gonna lose the patient and patient into a state of respiratory crisis, and you cannot treat the patient. Okay, so patient who have respiratory issues, cannot breathe, etc., and you suspect myasthenia gravis, please intubate the patient directly. This is always the answer in exams. So going back to our talk about the diagnosis, we talked about the clinic. Serology, you can use 3 tests. There is acetylcholine receptor antibodies, anti-muscle specific kinase, anti-lipoprotein receptor related to protein B. The most used one are the first one. Second one, you may see it sometime in the exams, but guarantee the first one, you should know it, and most of the time it comes in the exam. EMGs will show a discriminal response. What does it mean? It means that every time the patient uses the muscle to contract, you will see the EMG, the voltage of the muscle contraction start to decrease gradually, okay, which is at the end will show no muscle contraction at all. And this is high yield, very important, guys, never forget this. Always, any patients who have myasthenia gravis, screen for thymoma, so order CT of the chest please. That's very high yield exam question, okay? When it comes to the treatment, actually it depends on the situation which is we have, okay? So if we have a stable patient who have symptoms of myasthenia gravis, for example, this patient who is stable, have normal saturation, normal respiratory file, PFT is normal, everything looks good. In this case, we're just gonna start our cholinesterase inhibitor drugs, pyridostigmine. We will not give anything else. We will do support therapy, and we will follow this patient. Sometimes also you can start immunosuppressives like cyclosporin or eculizumab. Steroids are not the answer most of the time. You can give steroid to decrease inflammation, but in the last guideline is kind of knocked out, so they don't do this anymore. So this is in case of stable patient, okay? But if you have patient who have respiratory insufficiency, or patient who cannot breathe normally, or patient who have a bad ABGs, which is a high CO2 and low oxygen, etc., intubate the patient as we said, and then give IVIGs or plasmapheresis. Which one is more done? I think plasmapheresis is more done, and I think it's most of the time this is the answer, but one of them, okay? Sometimes even you can do both of them. In case of exams like step 3 or CCS, you need to do both of them, okay? Order IVIG and plasmapheresis. Don't order steroids, okay, because it's not in the last guideline. And order thymomectomy, okay? You need to once you discover in the CT there is thymoma, remove it by of course calling the thoracic surgeon. And this is a table comparing both Lambert-Eaton syndrome and myasthenia gravis. Clinically, the only difference that you will see is the myasthenia gravis will get worsened by using the muscles. And Lambert-Eaton syndrome will be the opposite. It will get more better once you use the muscle. Also, in Lambert-Eaton syndrome, there is a decrease in the deep tendon reflex, and there is autonomic dysfunction. So look at patients who, once they stand up, they lose their tension, or they have orthostatic hypotension, okay? And the thing which is I want you to look at, which is yep, here is the second line here. The important thing, myasthenia gravis associated with thymoma, so always order CT here. And small cell lung cancer is associated with Lambert-Eaton syndrome. Never forget this, okay? This is high yield. Small cell lung cancer associated with the three conditions. Sorry, this is C. It's associated with the three conditions, okay? The L is for Lambert-Eaton syndrome. The C is for Cushing syndrome, okay, because of the paraneoplastic cancers secreting ACTH, so you have Cushing syndrome. And the S is for syndrome of inappropriate ADH. It will secrete a atopic ADH, okay? Never forget this. This is super important. That's a mnemonic, okay? Mnemonic. How you remember it. Small cell lung cancer. S for the SIDH, lumbar for Lambert-Eaton syndrome, C for Cushing syndrome, okay? And this is the end of our talk. Thank you so much for attending, and see you the next case.